Okay. And then the topic that might be difficult so I'm registered. Only the PowerPoint. Okay. So I have to listen. That's nothing about nothing good. You know what I would do? Okay, here's the recording. That's okay. Yes, yes. Okay, let's start. So, ladies and gentlemen, it's my great pleasure and honor to have here Professor Georg Northoff. Professor Georg Northoff is really an expert. He is a philosopher, he is a neuroscientist, he is a psychiatrist, making together three different disciplines, and it's very, very important to have this new innovative approach to mental health. It's very, very important to have this type of person. His studies are very, very incredible, and begin with the idea about why and what the interface between mind and the brain is able to explain the complex phenomena such as the self, such as the many very different constructs which are derived from this new type of approach, and I found his studies very innovative for our discipline. So I don't want to take other time, and so I will give immediately the word to him for his presentation about personalization, which is a very interesting theme and topic about our discipline. Please, George.
Wait and see. Thanks so much, and also thanks for the invitation and the kind words. And I'm really happy that it's resonance in such an alternative approach. I'm very good with that. So thanks so much. I'm really happy that we picked it up. So what I want to present you is about spatiotemporal psychopathology, what it is, and why we need it. My particular focus on why we need it. Because clinically in psychiatry, we don't have biomarkers. We're really lagging behind. For instance, look at this slide. Look into cardiology, oncology, or this morning we have neurology. We have markers. We have predictors. Yeah. When you come into cardiology or oncology clinic, you get diagnostics. You get a blood report, you get an X-ray, you get a EKG, and so forth. And you get that in a stepwise procedure. Okay, this is defining that. Okay, this suggests you may have that. For that, you need to do that. Yeah. So that, and in particular, oncology and cardiology are disciplines which have developed in the last 20 to 30 years. Huge. Yeah. So now, how is the situation in psychiatry? Next. Yeah. You come to the psychiatric clinic. You get an interview, maybe DSM, semi-structured, 5 minutes or half an hour. Then the diagnosis is made. Diagnosis can change. And then you try to put some medication on it. And that is, of course, there are some guidelines, yes, but then you do try. So I hope that I don't offend any of the clinical people here. And I'm a clinician myself. So, and if you, let's say, have no time to longer listen to me, but the one mantra I want to convey, diagnostic. The progress in cardiology and oncology came through new diagnostic. When I speak with psychiatrists worldwide, we have no time for diagnostic, we don't. And that's really strange. Speak with your peace. So we need the diagnostic. But what is the problem? Why don't we have proper diagnostic? So let's take a step back. We published a paper in 2022. Let me put the chat. Sorry. I know I'm not allowed to move here because the mic is here. That usually I like to move because it's stimulating thoughts. But so we formulated it in the paper in 2023. Really, I think there's a double crisis in psychiatry. So there's a crisis that we lack the mechanisms. We lack the mechanisms from the biological neuronal to the symptom. We don't know them. And you know, there have been various classifications, DSM, then RDoC, HiTop, who have all their ideas about the mechanism. But we don't really have a direct link between, let's say, systemic neuronal features, regions, networks, and symptoms, or specific receptor types and symptoms. I was the resident, I always try to look whether there's specific receptor profiles related to specific behavior types. Recently, I spoke to one of the leading psychopharmacology experts in depression in the world, is our institute. And he said over 40 years with fantastic research, he was not able to really link a receptor profile to the behavior of the symptoms. So we are missing something. And that's, of course, I'm a philosopher, I always try to dig deep. We are missing something. What on earth are we missing? And that's the other side here you see on the right side, the crisis of subjectivity. Yes, there's a lot of phenomenology, beautiful phenomenology around Stangelini, Thomas Fuchs, others. But they restrict to experience. They don't make the link to. And so I formulated, and now there is a lived experience. But yet again, the lived experience is not really the subjective experience of the meaning of the symptoms. And that meaning of the symptoms, this is what I mean by symptoms. You all know, we all can have auditory hallucination, but maybe 3 in this room are only diagnosed with schizophrenia. Why? Because you attribute a certain meaning to your auditory hallucination, and that brings you to the psychiatrist. This is this meaning. That's what I mean by subjective experience, the crisis of subjectivity. And where on earth, and now you converge the two, the mechanism and the experience, where and how is this meaning generated? So Northoff will tell you that's dynamics, that's spatial mechanism, and you will see a lot of it. So summarizing again, yet this, what we're really lacking, the brain to symptoms experience is prior to the symptoms. You will see I provide data. So usually we consider, oh yeah, you have symptoms, and then you have a little bit of experience as a concept. No. Experience is basic for your symptoms. You will see several lines of data to my own surprise. So that's why we see the next slide. You see inner time and space, the brains, your experience, your consciousness of your time and space, or the time and space in the brain, and how it relates to the time and space in the environment. That's what we consider as a basic disturbance. So basically, there is this, what I try to flip out here is an intermediate level between, let's say, the molecular level, the biochemical level on the one hand, and the more symptom and systemic. Yeah. So this is basically like consider glucose in diabetes. Glucose is not a cause of the symptom. You have increased glucose, but you have symptoms all over. You have symptoms in the eyes, you have symptoms in the toe, and all over. Now, if you weren't knowing that this is all related to glucose and diabetes, you would say these are different disorders. Yeah. So glucose is a basic disturbance, and the causes of that can be insulin and molecule. So here, I'm not, and that's very important here for the biologists among you, I'm not claiming that I have the causes. Yeah, it's an intermediate level of a basic disturbance. The concept goes back, some of you may know, to Minkowski in schizophrenia, who thought abnormal time experience is lived experience, lived time is a basic disturbance of schizophrenia, and he picks it up and puts it into another biological context. So this is why I get this picture. So now, and that's why we developed spatial temporal psychopathology. The first papers on that came out in 2016. It was ridiculed by some reviewers and some other journalists at the time that it is trivial, which hurt me personally a lot because I really believed it. And now we try to provide support for it. So, and here I give you examples of that. So for us, mood disorders are not just mood disorders. They are speed disorders. The guys are too slow. And that affects your mood, yes, but also your movements and your cognitions. And you know that, as clinicians, you know that all these domains are affected. And I will show data for that you can support this also on your own grounds. Yeah. And psychosis schizophrenia is not just, for me, a cognitive disorder or sensory disorder, it's a precision disorder. They're imprecise, both spatial and temporal. So I know this is very unusual what I'm saying here, but I will provide more flesh to the bone in the following. So important is that I really characterize these disorders as by spatial temporal basic disturbances. Yeah. So and that requires a new view also on phenomenology, in particular on how you analyze brain data. So we had it this morning, give me brain data, give me behavioral data. I will not conflict with your standard thing which you publish I will provide a different dynamic view on the same. So, and one key factor of that is really integrating the subjective objective, the experience discipline. Because that connection generates the symptoms, and I will provide support for it. So I'm a big fan of phenomenology, but phenomenology in relation to it. So, and that sometimes puts me also apart from phenomenology. So now I will show you in the following, that's the background of what I'm doing here. It may sound a little strange to you, but I hope at the end it will not sound as strange anymore. So what I will now try to use, show that we have different markers, space and time, in your experience, in your brain, and that relates to it. So it's an explicitly spatial temporal view. Because I say that spatial and temporal features are similarly manifest in both brain and experience, and that shapes the symptom. We speak of the cognitive. So now I show you how you can, and I don't want to go into theory here, I really want to show you very hands-on approach, how this can potentially lead to diagnostic markers for differential diagnostic. And then in the second half of my talk, I will show you some initial examples of spatial temporally based personalization of therapy. So it's a very practical clinical talk I'm giving here, which has a huge theoretical neuroscience background. So when I start, because it's also in Genova, and I appreciate all your work on that and the interest in this approach with phenomenology and with some of the things. So I consider phenomenology, the subjective experience, people like Stangelini, Thomas Fuchs, Parnas were doing as a starting. For me, they, particularly the Denmark group, has fantastic interviews. For instance, the experience, the E-scale about the self-disturbance. But for me, it's important that it's practically applicable. Because I want the patient, I want this to be applicable. Yeah, in the private practice, in the hospital, as real screening clinical tools. Yeah, and if it works clinically for differential diagnostic, you can also not argue that the spatial temporal approach is completely nonsense. Because if something works, if the car drives, the engineer must have done something. So I show you now some of our phenomenology side of things. So one of the output of that is together with one student from Thailand, we developed a time-space experience scale for anxiety. And this is self-report. So for me, the self-reporting is very important because I know interviews by the psychiatrists or phenomenologists are important, but it's not clinically realistic. Yeah, nobody has time for a 2 hours interview with a patient. So you want self-rating scales. And usually I trust the patients. Yeah, if you give them the right cues, I trust the patient. The phenomenologists usually often don't trust the patient. They say, no, only we can. So it was very interesting experience. So here we developed a time-space scale, time-space experience scale anxiety. And so these are basically, we had a much larger number of items that we, through various kind of principal component analysis and various other statistical analysis, we boiled down to these 8 items. You can see, for instance, I can tolerate unpredictable future events, yes or no. My life is determined. Myself right now has long distance to myself in the past. I think the space around me is closed or bounded. Anxiety, which is very important. I think I'm locked in from the locked external world. So, and then what we did, so with these items, that's what we call the CSEA clinical scale for time-space experience anxiety. And with that scale, then first we had some other measures. We had the back anxiety inventory for VAI for anxiety and for depression inventory. And you see, we also had a spontaneous mind wandering scale. It's a very short scale, spontaneous mind wandering deliberate scale. And we have very good experiences because it's really, particularly as spontaneous describes it, literally the spontaneous dynamics of your thoughts. And you know that in depression you have abnormal ruminations and the thought dynamic is abnormal. Just published a paper on time scales of thought, PNS. Yeah? So even there we apply this. So and what we observe, this is a mediation model statistically. And we also observe, so usually the traditional cognitive view would be not your time and space experience, yes, okay, but we don't really take it seriously. It's a consequence of your sin. So if that is the case, if that were the case, then you would expect that the hystea is the dependent variable and anxiety is the mediator and mind wandering is the independent. But that was not the case. It was the opposite. Your time and space experience is the independent variable, and that affects your anxiety through the mind. Here, and you see the same for the depression. There's a full mediation model, and you will see other data supporting exactly the same thing. So this is, remember when I said initially, this time and space is a basic disturbance. This is the basic disturbance on the psychological plane. Yeah. Your time and space experience is altered. That in turn changes your cognition, and that in turn makes it patient. So that's really a reversal of the traditional cognitive view. Because the cognitive view would say time and space experience is just a consequence. These data say the opposite. So now, here, then, of course, as you know, there's a huge discussion about how can we distinguish depression and anxiety. And these are the same patients. This is a sample of 50 subjects. And so we did some machine learning, detection of anxiety, BAI, like anxiety, BDI plus, and you see relatively good prediction for such a short sample. And then we said, is our scale really related to the anxiety or the depression? You don't know. Yeah, could be both. So then we did a 4-group analysis. So we did patients with high anxiety and high depression. You see, these are the scale cost, sampled and scaled, normalized. That's why you have the negative values. Then you have high anxiety and low depression. And you see in the both high anxiety groups, you have high hystea score. Whereas in the low anxiety, high depression, low anxiety, low depression, you have low hystea score. And then we also did a correlation here on the 3 groups on the very right, and you see the same thing. So that suggests that really our scale is really more about anxiety rather than just depression. Potential screening mark. I do not say that I can make a differential diagnosis, but it's a screening tool. Yeah, it gives you an idea, maybe this patient has more anxiety, so we need to have subsequent more specific tests. Yeah, or if the patient is maybe in this group, or not, let's say in this group, in this. Yeah, so it's a screening instrument. That's what I want to use these scales for. They're all available. So now, then we did also with the same patients, we did, I will tell you later, the personalized breathing therapy. I show that later. But here we compared the scale before and after the breathing. And the first thing you see upper left, so this is a clinical time space experience, anxiety and BI. And you see in all 3, each line is 1 subject before and after. And you can really see that the majority of all the subjects really decrease in their system. So that suggests really it's malleable, it's flexible, it can respond to therapy, which is exactly what we hoped. And then you see here down there, the of course prelim, because you see the number of subjects not that high. But so we compared the post-intervention hystea with the pre-intervention hystea, the post-therapeutic difference in the scale, compared that with the BAI before and after, and you see a positive correlation. So that suggests maybe that the change in your time-space experience might also predict your change in anxiety. Potential, this is early days, of course, because we need large-scale number of subjects. Studies here, let's say 500 or 1,000 subjects, could serve predicted. So you see, I try to characterize the spatiotemporal features here on the phenomenological experiential level. Now we go to the next disorder. We also developed a scale for time and space experience in psychosis. So this was done one PhD student is actually a practicing psychoanalyst of psychosis in Portugal. Felipe Arantes is a really good psychoanalyst, fantastic of psychosis. You can imagine it's a very difficult field. And he's a brilliant phenomenologist. And so this is interview-based, and we included about 20, 40 items, and you see these different time and space items. I don't want to bother you with all the details, but we mainly focus on synthesis of time and space, which, as you know, key for schizophrenia, but also on other like speed, extension of time and space. More details will come out in the subsequent slides. But what is important here, let's say, so we compared, this is interview-based. We compared psychosis group with mood disorder group and healthy subjects. And you can see certain items. So the first line is always the psychosis, the schizophrenia. The second group, you see the affected people, the control people. And you can see that in the different items, sometimes you had quite a good differentiation. For instance, in item number 7 is experience of time fragmentation. It's only the psychotic people, not the affected people. Same in time 8 is premonition, typical for psychosis. And then you had certain, like for item 4, this is speed of time. You saw both psychosis and mood. So there you already see maybe there's some potential overlap and similarities, which will be discussed further in the next slides. So one question arises in this: how is time-space experience in psychosis, which is well documented, Stangelini, Fuchs, we all know this. So this provides a quantitative, and now we also develop a time-space questionnaire with 40 items for all disorders, depression, anxiety, psychosis, and PTSD. So here the question, we ask our question: how is the time-space experience related to the other symptoms of psychosis? And we were very lucky. So this is a collaboration of our group, also with the Denmark group, with the Parnas group, and they developed this interview for self-disturbances. As you know, they speak of a basic self-disturbance in schizophrenia and psychosis, which underlies and drives the expression of your symptom feature, and is almost more like a trait feature, the basic self-disturbance. And this is very well established. Various studies with this 2-hour, 3-hour interview have been published. And our question here was, how is that related to our time-space experience? So when we worked together with as a postdoc, like Karl Erik Sandstedt, I said, Karl Erik, who is more basic, the self or time and space? Because it's a basic self-disturbance. So, and we developed, and this was done by Stefan Lechner, I think you know him. He did fantastic network analysis. So I know I promote the own paper here, but really read the papers in psychopathology. He did fantastic analysis and also very nice phenomenological interpretation. So the first thing what we did, he did a principal component analysis of the different time-space items in this scale for time and space experience of psychosis. And he got basically 3 different subcomponents. You could see the time-space synthesis, time perception, speed, and social space. And here you already see time-space synthesis might be the most specific for psychosis. Time perception and speed, so also depression and space. And you will see. And then also here we did again the mediation models because we wanted to know who's more basic, time or space. It's the self-disturbance, it's the EASE here, the ERS, experience of anomalous self scale. So if the EASE, if the self-disturbance more basic, it should be the independent variable in your mediation. So it should be on the left where the red stuff is. If the time and space disturbance is more basic, then you would expect that the red stuff is always in the low left. And you see the data supports it. It's a full mediation. So meaning, even prior, there is even a more basic dimension beyond the basic self-discernment is your time. So meaning, your time and space experience has an impact. These are BNN, are the born sensory symptoms, basic sensory symptoms of psychosis, as through the basic self-discernment. Yeah. So you have, and that's what you will see later. So then he did various network analysis, read the paper, complex statistics, and you can see basically the result of all this is really a hierarchy of layers of psychopathological symptoms. So meaning at the very bottom, you have your time and space experience. And even there, you have a certain hierarchy that your time perspective and time synthesis is even more basic than the space. This is SOSP. Then comes the self-disturbance. Then comes the basic symptoms, sensual symptoms that goes back to Huber in the German tradition. And then comes the PANS general, the unspecific psychotic symptom. And on the top, you have the delusions and the negative positive. So you really see a clearly hierarchy. And on the phenomenological level, and this is the pure psychological phenomenological, we associate this as a background for you experience your symptoms against an abnormal spatial temporal background. And it's the same also holds for us. Yeah. So, and that's why we speak of phenomenal reflections. And so I think this is very important because we hope that we can use this also later for differential diagnostics, such a hierarchy, because certain people might have the primary deficit in the bond and not in the self. Yeah, this might be secondary forms of psychosis. So if you know exactly the layer, then you know where to interfere. It's like in internal medicine, you have this change of proteins and enzymes. If you know at which level the protein is abnormal, then you know where to interfere. That's why I'm trying to build up these kind of, also in the neuron. Yeah. So then how about differential diagnostic? So this is another paper which just was accepted by Stefan Lechner. He did a very nice job. So same data set, again, the interview, but, and we had this in schizophrenia, schizoaffective, bipolar 1, bipolar 2, and NDD. So it's a mixed group of subjects. As I said, it's Germany, Mannheim, Portugal, and Canada. And you can see here, we compared all psychotic versus mood. There were certain items were different, mainly the synthesis of time and space. That's really true. I mean, I think Stangelini pointed it out earlier. It's really they're abnormally constructed. Yeah, it's the construction synthesis, what the phenomenologists call synthesis, which as the scientists are called construction or constitution, is abnormal. Yeah, and I will tell you later what I suppose why that's. Yeah, and overlapping items, you can see this. Here he described it. You see here the overlap, the upper bar is basically speed, future present, future dominated by past. That's where mood and psychotic were more similar. But here on the left, you see sensory bombardment, premonition, spatial disorientation, time synthesis, various items, typical for psychotic. So here you see potential for differential. Yeah, and that's clinically very important because you need to know, is this a bipolar or depression patient or psychotic patient? Yeah, that's important. Even with our current lack of specific psychopharmacological, maybe the MDD patient, maybe you can try to do transcranial magnetic stimulation with them. We'll come back to. Yeah, so that's really potential. And another line which I owe to you, and I really like. You said, okay, if I understand you correctly here, the bipolar people have time perception change, but maybe mainly in the suprasecond or second, not in the millisecond. So why is that important for Northoff? For Northoff, this is important because this is about timescales. Timescales describe the duration of a process. Yeah, like your heartbeat, 1 second. Your breathing is much slower. My lecture is even a longer time. Yeah. So, so you describe, and these time scales which we measure, yeah, these are different tasks with different time scales. So for me, the difference is mainly in the time scale, not in the cognitive process. You see, as a cognitive guy would say, I don't care about it, it's a different cognitive process. No, it's the same cognitive process operating in different time scales. And the time scales might be the primary disturbance, the basic disturbance. You see, I'm trying to confront that with the cognitive approach, how that basically reverses. Yeah. And so this is very important for me. This is another thing. There's a beautiful paper, I'm sure you noticed, by Vogel et al. In Bonn, with a micro and macro layer. I love this. Yeah, structure, flow, micro, macro layer, and that also goes with a fantastic work by Tönnes and Stöcker. And we converted it in a paper with an Australian guy, with Lachlan Ken, that we have really micro and macro layer. So now, why is that related to the left one? Because micro and macro layer are different time scales. So my assumption, the micro layer is a time scale in the millisecond range. Yeah, let's say from 0 to 50 milliseconds. You're barely aware of it. You're proto-conscious, you're pre-conscious. Or I consider in the 2014 book, I spoke of pre-phenomenon. Yeah, that's about the time range. But if it's about 1 millisecond to 50 milliseconds, I can investigate it in the brain. Yeah, there you can make inference. Whereas the macro level is more the second. So, and as I said now, which is now comes from phenomenology, and I think Andreas' paper really tries to lend support from the psychological, phenomenological level. We try to do similar things now on the neuronal level, so that we establish a micro and a macro level. Why is that important clinically? You say Northoff go home or your basic science are not interested in. You should be, because there may be a disturbance only on the macro level, not on the micro level. Depression, for instance, can get from or bipolar. But there may also be disturbances on a micro level, psychosis, and that micro level might affect the macro level. So what is specific for psychosis is not the macro level. That might be similar to the depression. And that's what our earlier data support, the micro level. And I will show the support for that on the moment. So, conclusion of all of this, I really hope that we can use some of these instruments or others or tests which you developed so well for clinical data for screening. But we need to analyze them in specific. That's my mantra, temple special. Some of them, because that's where the difference is between the different subjects and disorders, not in the average. So now I show you some psychological or psychophysical testing. It's not the same as phenomenological, so I make a very careful distinction. And for instance, I show you here some visual task. It's a motion suppression task. So this is a task. You see this here. You have these little gratings there, and they move in a certain direction, and they move either right or left. This is a task with a high refresh rate, which I would not look at because it's so complicated. We have now another task, which we use for the clinic. And people have to decide whether it's moving left. And what we see here, and there's a small and a large stimulus, and you see here, first, the traditional analysis, here we did this in MDD, severe depressed, you see it's a good number, now we have even more with the paper in revision in Science Advanced with 300 patients. And you see that really the depressed take longer. But you see clinically there's quite an overlap between healthy and depressed. You get a significant somewhat of a large marginal. Okay. But now look at the variability, coefficient of variation. You see first you see a higher p-value in the group difference. And what is important for the clinical side, you see at least a certain intercept. Yeah, that's what you want to do. Yeah, and that's really, you see, and that's why I'm saying here, you also correlate them with the variability with the symptoms, and you see the lower the variability, the higher the psychomotor limitation. And that's important. This is not free. Why? You have your visual input. You do not process them in a variable way, and your psychomotor. There's another paper, which I will not retell, where we show that the direct connection from visual cortex to motor cortex relates to psychomotor. Yeah, that's why it's really psychomotor and not just motor. So, and here you see basically we have a lower trial-to-trial variability, lower coefficient of variation. Now, in schizophrenia, you see, at least in a subgroup of schizophrenia, you see the opposite. Yeah, you see here, upper left on the second side, you really see one subgroup of the schizophrenia, we did a lot of Chinese clustering and so forth. You see, shows much higher variability, and look at the intersubject, single subject discrimination. Then we did my beloved mediation models, and you can see again, now you can see, yeah, come on, your variability is not relevant for the symptom. It is. It mediates the SI, suppression index for the duration. Basically, the variability is important in translating that psychophysical deficit in the suppression index onto the symptom. Yeah, so variability dynamics drives symptoms. Why? Remember, it's subjective experience. And here, it just shows us how the trial changes the variability in the schizophrenia. It's much higher compared to the So, and this is not only in the visual domain, but also in the reward domain. Is another paper we published and some other studies show similar. So now, how about thoughts? So I showed you some visual data now. Thought, this is one of my favorites. So we asked the subjects to indicate their thoughts, whether they're more internally or externally. That was done in intertrials, interval 15 to 25 seconds. They got a question and then scale their awareness. So, and that was done over a number of trials. And then you can convert that into a power spectrum. So there's a power spectrum of your behavioral data. Yeah, and that's what I would strongly recommend also for the time perception. Yeah, so it's the variability of your thoughts. You can basically scale your frequency, how often they change from internal to external, and the power. This was our awareness score. And you see, for instance, the healthy subjects, the upper, they have quite a good change in all frequencies. Sometimes it takes more time, sometimes less time when you change from internal to external. Yeah, internal thoughts about your own self, external about the environment. Whereas in MBD, you see no power and not much change. And that's exactly what these people tell you. I have no energy, and it's always the same thought. Yeah, ask the patients. They tell you. Yeah, and BD, bipolar was somewhat depressed, but somewhat in between. Here I show you the quantification. So here you did the mean power legit of your behavior changes of your thought. This is the power of your thought behavior. That's what and even address thoughts and temperature. As I said, we had 2 papers in time scales of thought last year in PNS published with pure temporal characterization of your thought. It's not a cognitive characterization of your thoughts by the content. Yeah, that's the difference. Yeah. And you can see on healthy subjects, they have a good power, MDD, BD are different. Now then we look at the frequency. That's where BD and MDD are different. The MDD guys are literally too slow. That's why depression is for me. Yeah, one of the reasons. Again, that could serve for differential diagnostic marker. And here, is it really relevant to the symptoms? Yes. Your power spectral density, the power, it's an independent variable, it has an impact on BD, and that's on your rumination. It was a rumination question. We really again see that the dynamic of your thoughts, the power spectral density, is the basic disturbance. It's always independent. So you can imagine when I saw these data, unbelievable. I couldn't, maybe there's something right. This is basic disturbance. Yeah. That really, and you saw it now again and again. So that's why I love mediation. Okay. So now let's go to the break. Because there's a lot of stuff. I focus on specific things here. And one thing which I really want to emphasize is phase cycles. So usually you do event-related potentials. Maybe you do some time frequency or power analysis, and that's standard. That's what you see. And then they discuss which frequency range, alpha, beta, gamma, blah, 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 with the ERP and 100, P50, P300. Yes, all nice and good. But these are the very output parameters, like fever. Fever is completely unspecific. Will not tell you anything. Fever by itself, when you just look at the value of the fever, it will not tell you anything about the underlying. Yes, something is wrong. Okay, that's, I think you already know. Yeah. Then, when you look at the fluctuation of the fever, the dynamic, maybe you get a little bit. Yeah. So, but then you need to go deep, and that's exactly what we try to do. So we go to the deeper layer of the brain. So, in one deeper layer, when you go into engineering, there's three basic signal components: frequency, time, amplitude, and phase. Phase cycles, your fluctuations, and you can measure these phase fluctuations. Yeah, for instance, here we do a Hilbert transform, you get phase abstraction. You can also do frequency sliding, various measures. I won't go into that. But this is important. And these phase cycles, let's say if you have a 1 Hertz phase cycle, it's 1 second. You have an onset of a phase cycle every second. However, these phase cycles are slightly unstable. It's not only always at 1 second, 2 seconds, 3 seconds, 5 seconds, 4 seconds, the 1 Hertz phase cycle, but 1 second, maybe 1.8, the other one instead of 2 second, and the next one is by 3.2 instead of 3.0. So the brain likes to be flexible. Yeah, and that flexibility might be too strong. That's what we call precision. So the typical task to do this is what is called oddball task or mismatch negativity. You present repeated stimulus, standard stimuli, and then the deviant stimulus or steady state paradigm continuously 30, 40. So here I show you from an oddball task, 1.3 second intertrial interval, and you can measure how much your brain follows the timing, the onset of the tone. So if I do this, I hope everybody can see this. I try to get a rhythm with my feet. Your brain will follow my foot. You cannot avoid it. You have no consciousness, no voluntary. So meaning, and how does the brain do this? It follows the phase. And then you experience synchrony. You feel the groove of the music. Yeah, and that's what you can measure with what is called the intertrial phase coherence. Yeah, it's basically how much are your phase cycles always at the onset of the external coherence. And it's a cross trial, so it's a variability. And you see that the schizophrenics cannot properly follow that external tone. So here you see upper left, you see the big yellow thing. That's basically high intertrial phase coherence in the delta frequency range. And then you see in the schizophrenia, you don't see that. And you see also here these little, I always call them cakes. The face, the red line is basically your phase angle of your ongoing phase cycles. And you see there's a certain direction in the healthy on the left. And that has been done quite a lot in different paradigms. And we refined this. We will look into some of the papers, particularly by Amari from fantastic analysis. You also combine that with some simulation and computational modeling. You will see that to really support that the space cycle is unstable and cannot properly shift. Now here on the right, you see we did the same in MDD. This is the NIH large-scale EEG data set with about 200 schizophrenics and 50 depression, and there's also some bipolar anxiety, typical oddball paradigm, as I said. And you see again on the left the schizophrenia. These are different data sets here. You see schizophrenia, you see quite well, there's really no yellow, really no phase coherence, meaning they cannot follow the timing of the external tone. The phase cycles of their brain do not follow the external tone. Whereas in MDD, you see it quite well, yellow, meaning they can follow the external tones. So that led us go right to what we call the temporal imprecision model of phase coherence in schizophrenia. Now we develop that into a whole imprecision model because we also see temporal imprecision on the spatial side. So then we say, yeah, this is a task state, but how about the resting state? Are the phase cycles already unstable in the resting state? If no, then the cognitive people say, yeah, this is just a cognitive thing followed by your task. But as you know, I enjoy to undermine these cognitive people and say, no, your dynamic is prior to the cognition. So then you need to show this, of course, in the resting state. And Stefan Lechner from my group, a very clever guy, he developed a very nice method of measuring phase angles, phase cycles in the resting state in a model-based way. Basically, you know exactly when the phase cycle is the timing of the phase cycle, and you plotted the actual data against that, and then you can see the discrepancy. So he doesn't need an external tone. And what he showed, and that's where the differential diagnostic potential comes in. So first, then he calculated of these phase cycles the sample entropy, again, times series entropy. And what you could see, you see upper right, you see higher sample entropy in the phase cycles in the resting state in schizophrenia compared to both healthy bipolar. And then he did very nice thing. He shuffled the phase because he wanted to see are the phase cycles changes, variability, is it systemic, is it systematic, or is it more random? Are the schizophrenic more random in their phase? And then you would expect less difference between the randomized and the original data. And that's exactly what you can see. You can see that upper right, you see that the brown line as the schizophrenics is less steep before and after shuffle than the black and the green line from the bipolar. And that's significant. So meaning they have more randomized phase cycle. When I do this and your schizophrenics, you cannot properly follow these movements. And if you cannot follow these movements, you have no idea of what I'm talking about. And then you say, oh, maybe Northoff has some interest. Maybe tonight he comes and wants to kill me or whatever. Yeah. Or I should not give him my address and so on and so forth, because you try to make sense of this. Yeah. Why do I focus particularly on it? Yeah. So, and then, of course, your own cognition is completely decoupled from the external world. That's a hypothesis which we develop. So now, so here you see potential differential diagnostic marker for really just this method already lessons. So there we did also for EEG, MDD, and bipolar in the alpha phase. Why alpha? Alpha frequency 8 to 13 hertz. And alpha, as you know, is mainly about input process. So if your alpha is high, it's basically like the door to the room. If that door is closed, nobody can come in, meaning your alpha is high. If the door is open, everybody can in, meaning your alpha is low. It's basically gating. Fantastic work by Klimesh on that. And you can see that in the alpha phase, in depression particularly, you see really decreased variability. And this is then also further. And then he did also the phase stuff. Remember what I showed before. I know this is a complicated picture. I just follow what I'm saying. It's basically that the phase is delayed and it's too slow. It's always longer than it should be. Yeah, but that's systematic. That's not random. So you have systematic slowing down of your phase in depression, but more random phase cycles in schizophrenia. Very subtle, but I hope now we try to develop that, trying to get large-scale studies where we try to put these kind of candidate markers into testing. Yeah. And now, what do we do in fMRI? So one thing, we had this discussion this morning about psychomotor retardation and agitation. So here, this was a student from China who listened to one of my talks when I was there. And then afterwards, he wrote me in May, he liked the spatiotemporal approach. And then he said he has an idea how to really support that. And the idea was pretty brilliant. So he said, okay, if it's really motor, then you would expect primary motor deficits in your motor cortex and functional connectivity to other regions. However, if it's really psychomotor, it's like spatiotemporal, you would expect that your global brain connectivity to the motor cortex is delayed in retardation and too early in agitation. So if your motor cortex gets sufficient and very quick input from the other brain regions, you're more likely to be agitated and anxious in depression. Whereas if your motor cortex gets only delayed input from other regions, from the global brain and also from visual cortex, then you should show psychomotor retardation. I think makes sense. So he applied a method by Raut et al., basically leg-based functional connectivity, where you showed basically how much is your functional connectivity from the global brain, you see it here in A, from the global brain to the motor cortex delayed. So you can test this by calculating the functional connectivity in a delayed way by shifting the TRs. One TR was a TR of 2 seconds, yeah, or early. And that's basically the method. I spare you the details, basically a timing of your global to local functional connectivity versus just the connectivity within the mode. So it's really a spatiotemporal approach. So and what he found, maybe look at the lower left in figure D. So all the red guys are the healthy. You see, basically they just go quite around the 0 time delay, plus minus, versus the retarded depression are the green ones. They have more time delays in the positive way. They're more greens when you shift towards 0.1. Versus in agitated depression, the blue guys, they're more on the negatives. So here you really see, so in a simple way, put the retarded are too late in their global connectivity to the motor cortex, the agitated are too early. And we did not show any changes within the motor cortex itself. So this is really what we say psychomotor versus motor. Yeah, that's why I say coming from outside. Could also be, we have another paper, 2021, from serotonergic, raffinucleus, and then Benedetta Conio, you may remember her, really show that top-down, bottom-up modulates the motor. But serotonin, raffinucleus is not primarily motor. So that's why we speak of psychomotor. And we have another paper where it really shows this from visual cortex to motor. So here on the right, we also distinguish between high anxiety, high agitation, low agitation, and then the low anxiety, because we really wanted to see, is it really related to anxiety rather than agitation? And you see it's different to entangle, but anxiety. So then the next question is, why are they too slow? Why are the retarded too slow? This could be a problem of both. Either they have too strong slow frequencies or not enough. That's very important mechanistically, but also maybe clinically. So and what we see, so here we distinguished between slow 4 and slow 5. Slow 5 is the very slow range in fMRI, 0.01 to 0.027. Slow 4 is 0.027 to 0.073. And we could really see that the retardation, the delayed functional connectivity in the retarded MVD was mainly in the slow 4. No. So it's a problem of your faster frequency. They're really too slow. And we have another paper published last year where we show the same for visual cortex. Yeah, it's really the slow 4, the faster frequencies, which not the slow. Yeah, and these are also correlated with the retardation score. And basically, we see the same here. This is a moderation for Hamilton anxiety score. You can see upper left is really the red curve as the really early functional connectivity from global to motor cortex. And you see that is really clearly mediated by the anxiety. So it's really, it seems to be particularly the faster frequencies of the infraflow. And as I said, this is important. And another thing, I probably keep that short, the self, I already spoke of the basic self-disturbance. So we developed, this is our basic neuroscience research, a three-layer topography of self, based on a large-scale meta-analysis, interoceptive property, interoceptive self, inner bodily self, exoceptive, outer proprioceptive, and mental self. And we had different regions, and the most important thing, that these regions were recapitulated. The insular was not only interoceptive, but also an exoceptive and in mental. And the same with the TPJ, temporal parietal junction, and the anterior medial prefrontal cortex. So this is real, like the Russian doors, the nestedness now on the spatial level. You could really see this. I will probably spare you some of the details. So here I go through faster because I want to mention some of the therapy stuff. You can see here we measured the time scales in psychosis. They're shorter in all three layers of self. You can see this, meaning they have no, if you have longer time scales, you can better temporally integrate the shorter time scale. And that's here also doing less than tasks. They don't react to tasks. You can see this here on the left. That's probably out of confusion. But I'll walk you through that. Here it's about depression. That we see a lot of activity in the DMN, default mode network, particularly in the cortical midline structures, goes together with the increased sense of self. This is earlier work and later work. Here we show the same then for the three layers of self. You see that the depression are the red guys. They have increased exoceptive global functional connectivity to the rest of the brain and mental, meaning your cortical midline, so your mental self really enslaves the rest of the brain. And that's what you see in the symptoms. Everything is about your own self in a negative way, but it's all your ruminations, your sensory input process is completely confounded by your sense self. So then we also, this is a meta-analysis, we try to build up this three-layer topography as a differential diagnostic model. Yeah, so that we can say maybe depression, the mental self is high, in anxiety, the mental self is low, the regions in trauma, we saw the exoceptive strong, and you see, but this is early stages. Now we're trying to get a larger scale data set with these different groups. With fMRI, you can imagine it's not an easy one. And that's what I'm looking for. It could already be even existing data sets where one reanalyzes them with some of these new topographic dynamic methods. So, and the end result, what I hope of this diagnostic part, is that we get something like that we get an algorithm. Okay, you find this, then you do this. When you do this, this is what we try to develop here for the self. It's an enormous paper included. So, every good therapy presupposes diagnosis. So that's for me the royal pathway. And remember this slide, it's empty. And of course, when I'm in my manic phases, I hope it will look like this. Yeah. When I'm in my depressed phases, it remains empty. So that's what I hope, and that's what we try to do. So now we say, I give you now some indications of therapy. These are very, very early stages. Have the slide back. Yourself back. That's even crooked. Yeah. Okay. So what is personalization? Purposefully designed variation between individual in an intervention therapeutic element. So now I say, look, you can use the space-time stuff for personalizing stuff. And I show you 3 examples. First example is very simple, breathing therapy for anxiety. Slow breathing has been around. You know this. When you go to India, there are all kinds of crazy breathing techniques. Unbelievable. We have a collaboration there with a meditation consciousness center. It's incredible. So what we do here, and the standard slow breathing rate is 6 breaths per minute. When you look online, that's what we do. So here, what we do, we test, and you know that people with anxiety often fast breathing irregular, typical high entropy in anxiety. And we test different breathing rates from 4 to 10 and have for 3 minutes. And after each, we have little visual analog scales about thoughts and anxiety. And we do this also in EEG mark. Here I focus on the psychopathology. So what we observed in our 60 subjects is that not many people had 6. There were only 10% of them. Yeah, the other had other preferred breathing rates based on EEG and visual. So this is quite amazing. For instance, one patient who didn't like 4, some people like 4 breaths per minute very much. But that person didn't like it at all because earlier traumatic experience. Yeah? So you see how important the personal life. So then here I show you again, this basically here on the right, just the psychological markers, some of anxiety and thought speed visual analog scales, and I'm a big fan of these visual analog scales. You see they're much lower for the optimal speed than for the 6. So basically I need to show, Georg, why do you personalize? We already have a slow breathing rate to 6. No, personalization gives you better. That's important. And you know, in psychiatry, you suffer from inter-individual variability. That's what I'm trying to do. So next. So now what are the therapeutic effects? So we test this. What is the optimal breathing rate? This is all an app. And the app will guide you. And if you're interested in it, you can provide the app. And then you do 10 minutes breathing in the morning, 10 minutes breathing in the afternoon, in the evening. And before and after the 10 minutes, you do 2 little visual analogs. How much ruminating thoughts, how much in them. Just very quick, yeah, because we need the quantity. So, and these are the before-after data. And you see, for instance, that most of this is a single subject. You really see that the anxiety and the thought speed, anxiety is too fast and too irregular. You really see this in almost all sessions. Each line is one morning or evening session. But really the difference in the different rhythms. 25 to 30 to 40%. Now, after 3 weeks, oh, sorry, I need to push it down better. Okay. Here you see on the right the back anxiety after T2 is after 3 weeks, T3 is after 6 weeks. You really have. So I do not say that this is the causal therapy, like stimulation of drugs, but it's like a plaster. Yeah, you can give the patient a tool she or he can use right away while you do the diagnosis. Yeah, and you can also use it. Let's say, I remember one of my patients here was a brilliant engineer. After I learned a lot from for the engineering, but she had anxiety. She had social anxiety. She could not give public talks, which, you know, is an academic, and she also ran a company, which is a disaster. So she underwent this breathing, and now before she has to give talk, she briefly goes into a corner or restroom, does her breathing, and then she leaves it. So it's an immediate tool, like the plaster, what we have. Yeah, and the wound is bleeding. Yeah, that's what I. Then we have another tool, is music therapy. So what do we do in music? We, again, the patients bring 6 preferred pieces. It's all for depression and anxiety. They bring 6 preferred pieces, and then we vary the speed of these pieces. 3 slow, 3 fast. And then we test this how does the speed of the piece impact your anxiety? And you see no surprise. And even in healthy subjects, you see, when you play the piece very fast, you get more. And you have more ruminating. So here you really see, it's also basic science very important, that your emotion and your cognition are dynamically regulated through speed. And if your speed changes, of course your cognition and your emotion may get more anxious. Finally, I'm happy as a manic, but it comes with anxiety because of this dynamic thing. That's the way the brain is working. Yeah. So here are the therapeutic effects. So here is the group statistics. This is about 30 people. You see, again, same thing in the morning, 10 minutes, 10 minutes in the evening. For each of these 6 pieces, you get the optimal speed according to your preference, and it's usually not the original, it's either slower or faster. 10% is the original. And you see really the reduction, in particular the anxiety rate, some other visual analog scales, thought racing. Focus on that now. And here you see a single subject, morning, evening, over 80 sessions. And you see the blue bars is before 10 minutes of music, and the orange bar is 10 minutes after the 10 minutes. And you again see that in almost all the sessions, you have a considerable decrease. So again, it's a rapid, immediate tool, like a plaster. And that's much better than cannabis or benzodiazepines. That's what I'm talking about. Particularly in Canada, where cannabis everywhere. When you come to Ottawa, you smell the cannabis everywhere. So all the cannabis advocates come to Canada and you can get it. I will not prescribe. You don't need my prescription anymore. Yeah, so, okay, so that's what you see. And that is important for anxiety. It's in almost every session. That gives the patient certainty. I know, okay, it worked yesterday. It will also work. That's, this is about anxiety certainty. And here you see the long-term effect. This is the anxiety sensitivity index. You see after session 2, this is after 3 weeks, you see quite simple as that. So these are simple tools. The breathing is already completely on the app. So this is something we can do. The music we also tend to put on it because we want to make it practical, applicable. We even have one study now going on. We combine that with psychotherapy before and after. If you're in a slow mode, you're more receptive to psychotherapy, to experiences, to work through your own self, and you shift probably the border of your consciousness a little bit more. So now, finally, I will do this 3. This is it now for more biological forms of therapy. I plan to do the same with all our diagnostic, and I showed you one single case, which we just finished, for stimulation therapy, where we use some of it. So this is a very severe depression patient, 36-year-old, since 2 years, severely depressed. You see the BDI, anxiety plus depression. Treatment, and it's unbelievable. All kinds of antidepressant drugs fail. A standard TMS, transcranial magnetic stimulation, DLPFC, failed. Psilocybin failed. Ketamine failed. Electroconvulsive therapy, ECT. So we did a lot of diagnostic in the guy with the following aim. So remember, I showed you some motor cortex and visual cortex in depression. So we, based on these data, we conducted single studies on visual cortex, TMS, and depression. Is proved to be effective, and in motor cortex proved to be effective. And we were the first worldwide to publish things on these regions, because usually it's on the BLPHC and those are needed. So here I said, okay, are you open to this kind of differential diagnostic thing? That we compare these 3 regions for you. The DLPFC TMS already failed, but maybe motor cortex, visual cortex, or better regions for you to stimulate. Because the next option for him, 36-year-old guy, was deep brain stimulation, which I'm carefully skeptical about, because the results are not so good and for 36-year-olds. So we did various lines of diagnostic based on our spatiotemporal approach. For personalizing the region, the frequency, and then conducted therapy. So first we did a test for prefrontal cortex and visual cortex. This is a visual and a verbal working memory. This is variant of the same task. One is verbal, one is visual. And in the separate imaging studies that's published last year, we showed that the visual task involved verbal memory, the visual working memory involves both visual cortex and dorsolateral prefrontal cortex, and the verbal only the DLPs. So interestingly, the patient only showed changes in the visual variants, but not in the verbal. So I show you that here. So here we had normative data, these the blue and the red or purple graphs is obviously distributions of normative data. These were younger and old normative data. And you can see that his spatial working memory capacity was more like the older guys, 60 to 90, rather than in the younger guys, the blue guys, which is his age, 76. So the guy behaving like an old guy, typical for depression, pseudo. And then we also calculate the duration, the response duration, and you see it's much longer, typical for depression. And here we used drift diffusion model to calculate the speed of your spatial verbal drift rate, and you see it's really the guys slow. So that suggested maybe the visual cortex is reaching for him. So this was a psychological thing. We also did the psychophysics thing. I don't show you. We did much more than I showed you. We did also this motion suppression task and so forth. So then we said, okay, if it's really the visual working memory task, then you would expect that the connection from visual cortex to prefrontal cortex is abnormal. And that's exactly what we tested in fMRI. We did what is called Granger causality from visual cortex to prefrontal cortex. You see the green dotted line decreased, whereas the reverse direction from dorsal prefrontal cortex to visual cortex was normal. So decreased bottom-up modulation, normal. Top-down modulation, so an asymmetry. That also makes sense. So nothing comes into the prefrontal cortex. And interestingly, you see this also on the lower right. We saw too much entropy into the cortex. So then, next thing we said, can we replicate that in EEG? Yes, again, too much entropy. So here you see the dynamic matters. And trust me, we use others. No. So the entropy was relatively specific. Yeah. So, and you see, is again, same as in I, because you want for confirmation. And we also showed too much lower left, high alpha. So the gate was literally close. Alpha peak frequency, especially the peak amplitude of your alpha peak frequency. You can see literally close is too high. Makes sense. Nothing comes into the peak cortex. So the guy is blocked. And then, interestingly, the practicing psychiatrist, he had also some EEG data before and after his failed DLPFC. It was what they, in practice, they do quantitative EEG. So it's a big hit. They make a lot of money with it. You see a lot of companies with that. And I'm really appalled doing this because this is pseudoscience based on the bands. But it is. In this case, it was good. He had some 9 or 12 channel EEG. And we thought, okay, why on earth did the DLPFC TMS didn't work? It should have reduced the entropy in the visual cortex and the alpha people, which you see in the table on the right. It didn't. Yeah. It rather increased the to make things worse and didn't decrease the alpha. So there you could really say, okay, why it didn't work? So then we say, yeah, what could be a potential physiological correlate? Because that's important to know very clearly. So this is where the computational model comes in. So we particular focus on the model, which gives us about the microcircuits with different layers. The upper cortical layers, layer 1 to 3. This is somatostatin neurons, and it's mainly input processing from the rest of the cortex. And the lower layers, alpha-albumin layer 4 and 5, mainly exocytosis. So what do we expect in our patient? We expect in our patient that there's too much processing going on in the upper cortical layers from the rest of the cortex, and not enough in the lower layers for five departments. And indeed, there are postmortem data which show, genetic data, which abnormal somatostatin indeed. So this is all based on physiological, I cut it short here, and so, and first, we converged our EEG data with the computational model. It's called Johnson-Ritt model. And you can see here on the left, so left is the empirical spectrum. It's a simulated EEG spectrum, pretty good, except the alpha-2 wasn't too good, but at least here you can see. And so this is basically, we try to reproduce the EEG of the patient in the model. So that's why we do a lot of computational modeling these days. And you see it's pretty good. So now this allowed us to test. Can we measure these flow interneurons in the upper cortical layer versus the fast interneuron in the lower cortical? When you see the opposite changes in the PNG, in the upper 1 to 3, we had decreased inhibition, meaning all the cortical inputs from the rest of the brain come in and are not inhibited. So you have an overflow of your internal processing, whereas your external processing is blocked. You have too much inhibition that it's blocked. So that goes very well with other data, and it's basically amounts to this. You have too much internal cortical inputs come in, and not enough, and the external inputs from the outer world are inhibited. So, and we have various other forms of simulation. The winner is clear. We need theta burst. We also tested for which kind of stimulation the theta burst 550 is one of the best. So, what are the therapeutic results? So then we stimulated in visual cortex. We did 3 sessions every day over 3 weeks, and you see the results. We had a very good decrease already in BDI, BAI, and here my little visual analog scales. Before and after each session, you see that even the single session had a good effect on your depressed, on the ruminating sort of anxiety. And this is the long term, this is from the practicing physician who acquired the standard rate G87 anxiety and PHQ for the depression. And you see this is over 2 years. So this is when he saw them every second month, over 2 years, all the therapeutic failures. And of course, the Red Cross, you can imagine, is us, the visual cortex stimulation. And you see that really helps. So it tells you how important the personalization is. Yeah, tells you. So now we're trying to do this in a larger scale study and try to initiate that in Ottawa. Somebody here is interested. I'm very open to that. And you really see how important the personalization of the treatment target is and how important it is driven by the mechanism like the visual cortex. And one of the biggest compliments this patient gave me is that at various slides, I made a much more extensive presentation for him. I ran through all the slides and explained all the findings that exactly matches my experience. So meaning that's what we need. We need to be close in our neurodynamic or neuronal whatever measures to what the patient experience, because that's our treatment target. It's not the symptoms in DSM or how they conception. So with that, I'm closing. And again, you know my mantra, diagnostic, in a little bit space of time. Thank you very much.
Thank you very much, Professor Northoff and Georg, for this very comprehensive, very, very interesting presentation. And I believe that we are only at the beginning of a fascinating journey about these topics. And your presentation is exactly in line with this new trend of this time. And we are now open to questions. I have 1 or 2 questions, but I don't know whether there are before other interventions. Please, Professor Ramon.
Okay. in this period, I'm studying social cognition in depression and schizophrenia. Okay, you suggest several things about schizophrenia and depression, but I ask, is it possible to differentiate, for example, depression from loneliness using social condition study? Okay, but also the time perception on neurophysiological measure, because depression is a syndrome, not a very illness. Okay, so could you suggest something?
Yeah, so first I would say, I would subject social cognition to the same kind of dynamic measures I applied for my visual task, entropy, speed, or the thought stuff. Because for me, yes, social cognition is just one domain besides affect, besides thought, because sensory process. Yes, some patients might have more dynamic deficits in social cognition than maybe in sensory input or maybe in their thought. But that's just a balance. It's just where is the basic disturbance the most manifest? It's like in diabetes. Some people have the symptoms more stronger here, sometimes more stronger. That's the same thing. So I would expect the same kind of. So first I would ask, okay, show me the experimental design. He already knows of the task, time series, number of trials. I would do a dynamic analysis, variability, speed, entropy. And then the idea of linking that to time and space perception is, of course, a very welcome one, because I would expect I would do exactly the same kind of mediation models which I suggested. So you have your social cognition task, measures dynamic will be the mediator, the time and space perception will be the, so he will be the independent variable, you the mediator, I'm the dependent variable, that's one, or the state. Yeah, so that's what I would, it's the same scheme, because that's what I mean by basic disturbance. It affects all forms of cognition and psychological function in slightly different balance. Yeah, exactly the same. Like a heart attack affects your vessels in slightly different ways. One needs to stand here, the other one needs to stand there. Same thing. That's what I mean by basic disturbance. And the thing with the loneliness is a good one. So I would need to go more into the phenomenology of loneliness. So if you, let's say, ask Georg, let's do a project on that. So I would read about, probably call Thomas Fuchs. Can you give me phenomenological papers about loneliness? I'm always calling him for literature, yeah, because he knows all the stuff. And or you in this case, and then say, okay, what are the features of loneliness which distinguishes from depression? And my guess is it's the dynamics. It's the variability, it's the slowness, it's the reactivity to external stimuli. So maybe in the loneliness, you're also slow, but you can still reverse it. You still have variability. Whereas in depression, you're slow and have no variability. Yeah, or the other way. So I would do a layer like, yeah, very tentative, but based on the phenomenology. Yeah, that's why I'm a big fan of these little visual analog scales. Yeah, if I don't know anything, that's what you did with the anxiety. We just had 50 questions and then separated the age for the scale. So it always starts for me the phenomenological, or if you have some behavioral data on those guys, then do a dynamic analysis of the behavior steps. This always starts for me. What I also said with your task. We first analyze those BD versus schizophrenia. Same thing. Yeah? Because due to this common currency assumption, which we have similar spatiotemporal features on neuronal and mental level, I can go back and forth. Methodologically, it allows.
The questions, please. Thank you for the beautiful talk. And actually, I'm not a psychiatrist. Okay, I work in neuromodulation, but I was really fascinated by the fact that you told that psychomotor agitation or depression might be related to a problem of frequency and phase relation of brain waves. So I was wondering, you used ITBS protocols to so high frequency protocol to modulate the visual perspectives, right? At the end, I was wondering whether just to normalize this phase relation and frequency relation could have been done also with, for example, transcranial alternating current stimulation of like in multi-site fancy, just to normalize the phase relation and phase dependency of several areas.
Good question. So this is something, so I did the TMS because that's what our people are doing. Yeah, but I completely agree. You want to personalize for TMS, TAC, particular TAC. So for schizophrenia, remember I showed this phase cycle imprecision. TACS is candidate. And so in depression, I think we're really there with the therapy. I mean, this case, it's a single case, but it's based on TMS, motor cortex, visual cortex studies, which we really publish. And then the step, whether it's TACS or TDCS, we can do this, test this for EEG. I didn't mention that we had the theta burst at 550 hertz. We tested that. We tested 1 hertz, 5 hertz, 10 hertz, 20, 50 hertz with auditory stimuli, in which reacted better in the computational models. I didn't show the whole story. So really the intermittent theta burst was tested versus the continuous. Also. So good question. And that I think what I want to use the computational model. Yeah, to test these kind of different stimulations. And in schizophrenia, the TACS is for me a strong candidate. But I'm still a little bit hesitant because it's too, I don't know which region. Yeah, because in schizophrenia, the topography is messed up. It's really the unimodal transmodal coil doesn't work anymore because, as you know, in fMRI, functional connectivity is phase-based. If your phase are too imprecise, of course, your topography is messed up. We have 2 papers submitted now, and one is in revision, where we showed this, particularly the exoceptive layer of the self, which is disturbed in early unmedicated schizophrenia, which makes sense. Yeah, you start with early sensory perceptual changes in your schizophrenia. Something has changed; it's becoming more intense or fragmented. Yeah, so it makes sense, and connection with the auditory cortex. So these probably could be target regions, but I need more physiological mechanistics. Yeah. And please refine the TACS. I want to have it more specific with respect to region and timing. Yeah, I need exact timing. Ideally, I would need to do this EEG or BCI based, brain-computer interface based, so that I can really know which is the phase cycle, and now I interfere. But the BCI people and the EEG people tell me, yeah, we cannot have as fast the computation needed for them. Yeah, because we are operating here in a millisecond. So I'm a little bit still in the exploratory phase for psychosis. For depression, I think of course, you could also use TAC, you could do a phase analysis. Yeah, that I agree with. And that's easy. You can just do an fMRI phase-based functional connectivity. We can do frequency sliding, which is also phase-based. So we do all that. That's so the step for TACS, testing for TACS, TMS, and depression. Sorry to say it's easy for us. The schizophrenia is. There we have a much better model. In depression, we don't have as good, the speed model I think is good, but not as good. I think the imprecision model is much more substantial, even in unmedicated patients, it shows. Even in fMRI and EEG. Yeah, so, but the therapy.
Questions?
Well, thank you very much for your talk. So I have a couple of questions. The first one is very basic. So let's say that you give about the space and time, so basic physiology of space and time. So let's say that you use a stimulus that doesn't have the time domain definition, like one single simulation, like a flash of light. Then you can measure time that the stimulus passes the retina, and then how much time it takes to go through the thalamus, the visual cortex, and you can basically follow the feed forward. Is there so the time that the stimulus takes to go from one user to another, it basically depends on the transmission of the signal. So which point the time changes can emerge from this. And this is what the first one. The second one is
let me answer to
Yeah.
that because that's a complicated question. So, I don't. Yeah, so that goes into the causal mechanism. I cannot say. I cannot really say. Of course, probably without the nucleus, subcortical cortical modulation plays a role. I really don't know. So this is probably where also the biochemical. We're trying to bring that into our computational model. So that we try to get data sets where we have in the same patients, we have fMRI and PET data. And then we try to converge those data with a computational model and then. So this is the kind of basic stuff which you can best do with the computational model or animal experiment. But that's where that comes in. That goes more into the causal mechanism. Where is this abnormal flow that's coming? That's basically the question. At what time does it come? It is already on the basic rates of the firing rates of the neuron. I'm not aware of any data, but I have never looked in depression models. Yeah.
And the second one is, so the perception of time can change very fast. For example, if you drive on the highway and you go like
But depends where you drive, from Germany or Italy.
after a while, your perception changes and you think you're going slow, and even though you're going very fast. So do you know if this change in perception is also impaired in
Yeah. Good question. So very good question. We have one paper, Too Slow, Too Fast in 2018 in bipolar. And so you have, for the way you perceive your external time is relative to your internal. Your internal time is your default, is your internal reference. If my internal time is very slow, I might perceive the external time abnormally fast. Remember, for instance, one patient who didn't speak at all, young girl, depressed, and she told me her, and afterwards, and she thought it's neurological and blah, 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 blah. No, it's pure mutism in the framework of depression. And her mother was with her, and then she told, and I asked her, why didn't you speak? Yeah, my mother, I know that my mother was speaking normal, but for me it was too, couldn't follow, and then I decided to check. Why? Because the internal baseline is too slow. Yeah, and then you perceive the other ones as relative to that, too fast. Now, the opposite, of course, is also true in your example. Yeah, when the external time, let's say you go from a German to Italian motorway, because the Germans can drive unlimited speeds, yeah, and up to 400. There was something in the press some years ago. Yeah, so of course, then your internal default also transitorily adapts. Yeah, and then you perceive it differently. So there's a remarkable plasticity, but your internal baseline, of course, takes longer time scales to change. Because if it were changed right away, then there would be no difference between you and your external environment. Mania. Yeah, that's probably what happens in mania. Yeah, where you completely reactive, you have no time delays. Yeah, you boom, 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 boom. So too fast and too slow is not good. That's okay.
Thank you very much for your presentation. I also have two questions. The first one is about the music therapy, and about the high frequency music. Because such as we call spiritual music, you know, this high frequency, like for the 452 Hz music. And can this music change the phase of the brain and avoiding the rumination and taking the brain in another state, and how it can be possible?
Yeah, definitely. Music goes through phase. That has been shown. You have phase coherence, you go with the rhythm, like this intertrial phase coherence, and schizophrenia patient cannot go. Not phase. The internal phase cannot be entrained by the phase, the time, the music. So again, I would see we try to personalize here the music, basically psychological, also EEG parameters. And I would do the same for depression. So in which frequency you need to present the music to make it meaningful for the rumination. So you want an EEG diagnostic, you want to ideally make a behavior testing for your rumination. And basically the frequency of your rumination, remember the sort task. Yeah, that I would do in those guys. And then based on that sort task, okay, where is the power spectrum of that person? And then try to interfere in that frequency. That's personal. Yeah, so I would do diagnostic. Yeah, spatiotemporal diagnostic. So here I would do the task. This sort task, ideally also some EEG, and then see which are the relevant frequencies and the abnormally slow frequencies of your rumination people. Personalize and then interfere in that frequency to make it slightly faster. So let's say your normal frequency in the healthy state is 12 hertz. Now you shift, let's say, it's just completely nothing really. Example. 5 hertz, yeah, you're in theta now in 5 hertz in the rumination. That actually is clinically realistic. Yeah, you're in 5 hertz. Now, if I give you 12 hertz, you will not react in your 5 hertz. Because it's too far away. You need to give 6 hertz. And then 7 hertz. That's personal. You see what I mean? Yeah. I'm a big fan of music therapy. Big fan. But when you look, we looked up all the studies, Cochrane review, the effects are mixed inter-subject variability, different protocols, blah, 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 blah. I hope you can improve it because I'm a big fan because it gives the patient a tool. Yeah, he or himself. It gives them also some agency. And you can use it. It's also a fun thing. And we had one of our patients, it was very interesting. She described it as 2 different forms of sadness. One sadness, which is really the sadness of depression, which she hates. And then one form of sadness, which she likes, is just mourning about her past event, more traumatic reintegration, different kinds of music. Yet another patient told us severely depressed, could not get up in the morning. And you know, for depression, they have to get up in the morning. If they stay, bad news. Yeah. Okay. So then she listened to techno music to make herself get up. Yeah. Was a 50-year-old woman. Yeah. So just to give you an age concept. She hated the techno. It made her aggressive, which of course makes sense, but she could walk. And we said, okay, let's titrate a piece which make her walk, but not aggressive. That's what we did. That's personal. So the music, I would even be symptom-based. Completely in it. That's the beauty of music. You can do that. Really simple patient. And listen to the patient. Phenomenology.
The second one is maybe so huge question, but I try. And can you explain us the potential connection between the new theory of the quantic mind?
Also, quantum mind.
Quantum mind and the spatiotemporal, if it's possible.
Yeah, see, there's all this quantum theory of consciousness, of probably what you're alluding to. For me, it's a time scale which is far beyond the time scale of your experience. So, of course, you get a spatiotemporal answer. So, the time scales of your consciousness are between 10 milliseconds, 30 milliseconds, auditory processing 10 milliseconds, and 3 to 5 seconds. That's the time scale, just the duration of your consciousness. For duration of 1 second, 1 hour, you don't have a consciousness. Yeah. For firing rates, 1 millisecond, you don't have consciousness. So, and for me, the time scales of quantum processes are the nano level. So that's why I'm skeptical of quantum theories. It does not mean that they have no relationship to consciousness and its time scale, but that's a cross-scale question from just what I've said already. Yeah. So you would need to clarify then the cross-temporal or cross-time scale relation. It's too much.
Another very quick question about your great expertise. What about the cerebellum, the alterations we observed and that you presented here? Because we published some papers about this, and probably you have talked with Andrea, with Alberto about this. And I don't know whether it's possible to postulate, to really hypothesize a main role of the cerebellum in the space-time alterations in many more of our disorders. And the second question rapidly is about traumatic experiences. What is your opinion about this, about the existence of specific space-time alterations in traumatic subjects, in subjects who have experienced a lot of traumatic experience?
Yeah, good questions. First, the cerebellum. So I'm usually a global brain guy, and that includes the cerebellum, but admittedly, we never really looked for that. Because I can be the main corticocentric and a little bit subcortical. Definitely, it has a timing experience. We discussed it earlier. Actually, the earlier hypothesis by Nancy Andreasen, I think, was a good model, an interesting model. Whether it's true or not, it's almost too unspecific for me. That's a positive. Then there's all the work by Mitai on cerebellum and schizophrenia, cognitive dysmorphia, Andreasen. Definitely. And has been shown. How much that has an impact on the kind of dynamic. Yeah, so I would imagine that depending on their own dynamic profile, let's say like the power spectrum, the different regions have slightly different impact on the matter. That's it. If a region by itself shows higher sample entropy intrinsically, the sample entropy it's more irregular in its frequency, spectral, has a higher spectral entropy. Yeah. So, and we know that the time scales, for instance, are shorter in sensory and longer in transmodal regions. Yeah. So that's definitely, and of course, the cerebral. So for me, the different regions, in a way, are all like little brains. The collection of different brains, it's like a group of 50 people, and each person contributing something differently, but they all act in global. Yeah. You cannot understand the impact of that 50-person group by just adding each person up or integrating, you know what I'm alluding to, information from each person. Yeah, you need a global approach to understand that and then see how the contribution of each subject contributes something. Why? Because each single subject contribution depends upon how many people are there in it. My contribution will be very different if there's only one person here or compared to all the other persons. Yeah, same thing. And of course, what was the second question again?
Traumatic experience.
Traumatic, yeah. Okay, as you see, we try to develop spatiotemporal models for different cases. The one model is imprecision psychosis, speed depression, anxiety, which is in revision. It's an irregularity model, too irregular, uncertainty. Trauma is continuity disorder. So for me, the spatial and temporal continuity is disrupted in trauma. And I developed that a lot with Andrea Scalabrini, whom you probably know, former PhD student, and now he's professor in Bergamo, and we still work a lot together. And I often explain this to my patients in like, imagine a river, the water is flowing down, and you throw a big rock into the river. It disrupts the continuity of the flow of the river. Most of the patients really like this comparison. So meaning there's some, that's what I imagine. But how to measure that, it's not fully sure to me. I'm not sure whether I can really capture it with the measures I presented. Not fully clear to me.
Really interesting.
And in our time-space questionnaire, the 40 items, we have some trauma-specific items included. And it goes together with, for instance, entropy, so the layer thing. Yeah.
I believe that we need to stop here. No. Professor Northoff for this great experience and this innovative line of research. Thank you very much. Can you get a feature?
Okay.
Thank you.
Thanks for mediating. It's not an physical, in Spinoza. But very interesting. Spinoza. Very interesting. We did some very nice.
Thank you. Because exactly 11 years ago, with my and memories. So I am now thinking to see the very important. I was very happy. Thank you very much.
Happy to share software methodology. Yeah. Right. Yeah. Just someone.
Is that set on my apology for the time? Thank you very much. Again, just yeah.
Devo tagliare Mirko poi.
Okay.